optimizing the patient and doing a preoperative evaluation in a COVID suspect or a COVID positive patient. Elective surgeries and emergency surgeries, whether to do or not to do. Why no elective surgeries? You see, in the initial time of pandemic, say about in the month of March or April, when nobody has a clue about the type of virus, what the symptoms, presenting symptom, what the treatment, how it's going to be tested. So much of chaos has been around the world. So everybody, the medical health workers, they are very scared of this. So we started abandoning elective surgeries. Even the government, the district administration, they have advised all the medical fraternities to stop the planned surgeries, elective surgery, postpone it for 1 month or 2 months, if possible. So, if you talk about the patient, if some patient, see a patient who is COVID negative has been admitted to the hospital in that time for elective surgery, he may be bunched with a COVID positive patient. So really get infected unknowingly. Second thing, if a COVID positive patient who is admitted along with the other patient for surgery, he underwent a major or supramajor surgery. There's a lot of macrophage activation, give rise to cytokine storm, and can lead up into fatal consequences. So to protect the patient, we have abandoned the surgery in the initial phase of pandemic. Second, to prevent the healthcare workers. See, the mortality of healthcare workers is almost 10 to 12%, which is much, much high. If any of the patient is admitted for a surgery in the hospital, in a busy hospital, he has to remain for 5 to 7 days in the ward. He has to go to OT. So minimum in OT, one OT, what we need is almost 8 to 10% of healthcare workers will be there. And so many theaters are operating in a complex. So they are the potent source to become a hot spot. So the government, not the doctors, they want the hospitals to get the hot spot. So we abandoned the elective surgery in the initial period of pandemic. Why to consider the elective surgery when they abandoned in the initial phase, maybe the March, April, May? Now, what it was thought? It was thought the primary wave. It was thought that the primary wave, which is going on, which have a peak in the month of May and June, and will start declining after that. And the growth of the virus. WHO and all other experts, they have claimed that this curve will go to the rise in the month of May and June, then start falling. Either it may become plateau or start falling. So the exponential growth will become a linear one. But you see the results. We are in the month of August. There's neither the wave has stopped or is going on the decline, nor the growth has become a linear. So a surgeon which was agreed upon in the month of April to treat a conservative a patient of acute appendicitis or acute cholecystitis or a patient of PIBD. Now, he will be telling how to operate appendix, otherwise get rupture, and the CBD stone is going to give jaundice. Or an orthopedic surgeon will tell, my patient is developing bowel and bladder syndromes, so I have to operate. So how long can we prolong? So we have to go for elective surgeries now. Emergencies won't be stopped. Labor epidurals, assisted deliveries, lower segment cesarean sections. See, if a patient of normal is going under normal labor, he has to shout a lot, so creating a lot of aerosol. We just can't prevent it. And so the oncosurgeries, the patient is diagnosed with cancer, is very injustice to not to operate him. So the emergency surgeries are going on in the pandemic initially and now also. The key factor, the caveat in this protocol is to treat each and every patient as a COVID positive until proved otherwise. So before going, let us categorize the patient. Who is the suspect? Who is the suspect? Who is the confirmed patient? And all asymptomatic individuals who have undertaken international travel for last 14 days. All symptomatic context of laboratory confirmed COVID positive cases. And all symptomatic healthcare personals or all hospitalized patients with severe acute respiratory illness and asymptomatic direct or high risk contact of a confirmed case. They are the suspected case. These are the cases which are going to give problem to all health workers, not for the confirmed one, because he is already labeled a COVID positive case. A probable case is the case whose testing has not been done by any of the reason, or even if it is done, it is not conclusive because maybe done in some wrong way. A confirmed case is a case which has a laboratory confirmation report of COVID positive irrespective of clinical signs and symptoms. This criteria is going to help you a lot in the management of the patient henceforth. These are some indications of high risk. You can take it from the history, comorbid conditions, clinical assessment, and the laboratory investigations. We'll talk later. Now, every patient which is going for elective surgery or emergency surgery has to come to anesthetic for preoperative evaluation. It is must in any of the season, not in this pandemic also, everywhere it is to be must. So for any evaluator who is doing a PSC, personal PPE, personal protective equipments are a must. To some who don't wear it, it's called a personal protective equipments, PPE. For those people who have worn it, it is called as personal painful experiences. I won't go into details. Each and every of anesthesiologists know about the details about the PPE. Won't go into the details, right? So any of the patient who's going for pre-anesthetic evaluation in a clinic, what it should have. Evaluator should be donned with PPE, not in the terms of a routine PPE, but any of the safety gadget he should have. Patient should be a 3-ply mask, at least. Because see, most of the patients who are coming to OPD, they are wearing a cotton or a cloth mask, which is not sufficient. So let it to get changed with 3-ply mask while doing a PSC, or as soon as the hospital administration, he should get it changed with the cloth mask. And usually we are doing in a closed room PSC, but in this time in the pandemic, preferably PSCs are to be done in a slightly open space, so direct contact with the patient is to be avoided. No crowding in the PSC room. The patients have to come one by one with either no attendant or maybe a minimum. Attendance should be restricted to nil or a 1 at least. To try to avoid the close contact. Every evaluator is to ask to take the history, to examine to take the history from a distance of almost 2 meters. And as a triage, the patient's body temperature, non-chest technique, and room air saturation has to be taken the first and foremost priority. And after each and every step of patient examination, hand hygiene is to be performed. Whatever things are available to us, it's not particular. And at the end of the shift or at the end of all PSC, there should be a cleaning and disinfection of the anesthesia cleaning. Pre-anesthetic evaluation, what should it include? In the history, definitely, the first we have to ask about the symptoms of the COVID-19. And after that, the most important is the epidemiological history, from where the patient is coming. Is he coming from containment area? Is he coming from a hotspot area? Is his family, somebody has suffered in the COVID-19 like symptoms or a positive case, a confirmed positive case? And occupational history, whether he is working somewhere, he is sitting alone in the room, or working with 3 or 4 people, or some in factory where the 50 to 100 people are working. So it is to be asked, just to have a guide of it. Things to be asked about the comorbidities and drug history, especially immunosuppressant. If he or she is taking, a special precaution has to be taken. Examination. Though it has been a dictum that we should pack our stethoscope, but thorough clinical examination, especially chest, you are examining, a stethoscope is must, and preferably it should be done from the backside of the patient, standing on behind of the patient, and room air saturation and temperature has to be taken. Most of the patients who are asymptomatic or maybe mild symptomatic, they have saturation around 90, 91 or 92. This is coined as happy hypoxia. In some of the patients, you can do a 6-minute walk test, and if the SpO2 falls by 4, it's alarming. It should be taken care of. And if the patient already has saturation at around 90, this test should not be performed. So after clinical examination, here comes the investigation. All the routine investigation has to be carried out with a special reference to WBC to see for the neutropenia or leukocytopenia. Then we have some special investigation, reverse transcript test, polymerase chain reaction swab test, the RT-PCR test. It usually comes in 6 hours in the private setup. In government, it takes a little more time, but it is still holds the current gold standards. Swab taken from oropharynx is the least sensitive or least liability as compared to taken from nasopharynx, and the best is from the endotracheal tube or from bronchial lavage. It constitutes 72% of the sensitivity. There are some optional tests also. COVID19 antigen test, which took 2 hours. IgG clear test, antibodies took 4 hours, and ELISA test took 6 hours. But these things, antigen antibodies are optional, and they are surrogate investigation. Why, I will tell you. In the testing CONUNDRUM of COVID-19, look at the picture. IgM comes from at the 7th day and remains for 7 to 21 days, and IgG at day 14. So we don't rely much upon the antigen and antibodies. The gold standard still is RT-PCR. Surprisingly, it was surprising to the extent of surprise. We have all the literature coming from China, and in our practice also we have encountered that the sensitivity of HRCT is almost 97%. In the patient with mild symptoms, you can get the bilateral signs, almost 9 to 10% or 15% of lung damage. So there are some more special investigations which are termed as a COVID profile, which includes CRP, LDS, serum ferritin. CRP is a surrogate marker, inflammatory marker is a surrogate marker for IL-6. If you have facility in a diseased patient, in a sick patient, if you have facility of IL-6, you go better for it instead of CRP. Serum ferritin is raised. When the serum ferritin is raised, it gives rise to activation of macrophages, lead to cytokine storm, and very difficult to control. D-dimer also done, so that we can timely start low molecular weight heparin. See, considering all these tests, no single test is fruitful. So it has been documented that we have to go for minimum 2 or 3 investigations to conclude the patient about the COVID status. Now we come to the protocol, or what is not the protocol, standard operating procedures, whatever it is. But for elective surgery, naturally the patient who is coming for elective surgery coming to the OPD of surgeons. So the first triage will be there at the surgeon's OPD. So we'll screen for the symptoms, temperature, and room air saturation. If the patient doesn't have symptoms, doesn't have temperature rise, room saturation is okay, then there's no problem. But if the temperature is more, saturation is going below 90%, sorry, he or she must be immediately escorted to the fever clinic immediately and should be reported to infection control department, and his line of treatment will be different. But if the patient doesn't have any of the symptoms, then patient must be instructed from the surgeons that he has to fill the form and patient has to go for HRCT and RT-PCR test. And will be instructed, the HRCT report will come within half an hour or 1 hour, but the RT-PCR will take at least 6 hours. So patient is instructed to give the sample for RT-PCR and do the HRCT and go back to home. And next morning, next day, maybe whatever it is, come with these reports. And if in the second visit, if these reports are negative, then the patient has to be proceed for pre-anesthetic evaluation, which we have already discussed. And after pre-anesthetic evaluation, it seems to be okay. There's no bar at this PAC level. The patient should get admission, and the rest of the investigation and all the other references for like kidney, for liver, and for the cardiac references has to be done, and surgery is to be planned. And before shifting the patient, the second triage is also should be given regarding the checking of the papers, checking for the investigation, again the temperature. Every patient before shifting to the operation theater should be checked with the temperature and room air saturation. Then we'll proceed for the surgery, which of course will be in a normal otherwise theater. One more regime which many people has adopted in my hospital, also some surgeons have adopted. there's a quarantine or isolation regime. So what a patient comes to you in OPD, he is requested by the surgeon, can he get back to the home and be in isolation for 14 days, RT-PCR and HRCT, and will report to surgeon. If all the reports will come normal, then he will proceed for surgery, of course, with the pre-anesthetic evaluation and admission. The advantage of this isolation regime is that we get an additional protection for the patient as well, for the healthcare workers also. So this is a very good regime for elective surgery. Now we'll go for the emergency surgery. What we have to do? Any of the hospital which is offering a 24 hours emergency surgery has to have a dedicated isolated ward. It is to be prepared. It is mandatory, not from our side, but also from the administration side. If the patient comes to a hospital, he should be admitted in the dedicated isolation ward. Then immediately the HRC, he should the rapid antigen test or COVID profile should be sent, and he will be sent to HRCT. If negative, if all the reports come negative, he can be shifted to a routine preoperative ward, and he is processed for surgery in the routine operation theater with due precautions, with all the precautions which otherwise we are taking in elective surgeries. If he found to be suspected, some of the investigation are deranged or some HRCT shows some signs, if he finds suspected, then he should be kept in isolation ward, and from the isolation ward with all precautions, with all protocols, he should be shifted to a dedicated COVID operating area and will proceed the surgery with all universal precautions. The donning of PPE and all which Dr. Deepesh will disclose to you. And immediately after operation, whenever time permits, the next day, maybe the next day morning, the swab is to be sent for the RT-PCR test. And while if the RT-PCR test comes negative, he should be continued in the post-operative ward. But if it turns out to positive, immediately shift to the isolation ward and will be there till the discharge. Something about the anesthesia concern of the COVID recovered patient, a patient who has has gone COVID positive and recovered. There's no definitive guidelines. Whatever we are prescribing, we are dealing with what we have experience of the COVID patients. So in that patient, if the patient who is recovered from COVID has come for the elective surgery, we should repeat the COVID RT-PCR test or plus minus antibody, depends upon the setup where you are working. If you have antibody test, antigen test, go for that. And inquire about the course of disease. What was the course of disease? How he was infected and how he got treated. Whether he was treated in quarantine home isolation, whether he was admitted, and if he admitted, was discharged from the ward, or he has been to ICU on BiPAP or high flow of oxygen. So the course of the disease has to be taken from the patient, and the sequelae of the disease, which has to be evaluated regarding the lungs, heart, and psychosis. There's a post-intensive care syndrome or any other organ damage. If you find that he or she has recovered completely, then proceed for surgery with all this precaution which I have mentioned. If still he has some residual, some sequelae of the disease is there, so you have to postpone the surgery for maybe a week or fortnight. And the risk of the surgery is always to weigh against the safety of the patient and healthcare workers.